and that's what speeds up the nerve impulse. So with that in mind, we might also consider the use of shockwave for Morton's neuroma and stump neuroma. Morton's neuroma is typically in the third, fourth web. Well, no, it can only be in the third, fourth web space because any of the other ones are going to be differently named. So Joplin's, Pewter's, Hauser's, Morton's, and then Ishland's neuromas. Ultimately, if you think about the anatomy of a neuroma and the surrounding anatomy, you're looking at, if we imagine this as being one met head and another met head, you then have a transmetatarsal ligament, so something that holds the two metatarsal heads together, and you have a nerve that sits underneath it. And so what then happens is that nerve typically tends to get caught between the two metatarsal heads, and so we're often thinking about somebody who's got a very hypermobile lateral column, or something with them stiffer. That nerve then gets compressed, and then you get the thickening, the fibrous thickening of the sheath that surrounds the nerve. But sometimes they are just completely normal looking. So you can have a pathology, a patient presenting, and the pathology presenting looks like a duck and quacks like a duck, but you get it scanned and it ain't a duck, it's nothing. And that could be if it's an ultrasound due to the person scanning. If it's a MRI, it could be because it's caught between the two slices. And equally, it might just be that they've been in so much pain that they've not inflamed anything, so it's not easily recognizable on imaging. But whatever it is, sometimes if you've managed to rule out the likelihood of it being sort of bony or capsular, so sort of a second MTP joint issue, or MTP joint issue, I should say, and equally where we're looking at stump neuromas, which are notoriously difficult both to operate on and to manage with injections and everything else, then there is an argument to be had for not cutting into the foot once again and using shockwave to be able to stimulate that